Well, ladies and gentlemen, welcome back to Gadjah Mada International Conference on Tropical Medicine 2022. Now we are heading to the last session today. It is Symposium 6 under the topic of NTDs, and the session will be led by our moderator, Professor Kusnanto Josef from Universitas Gadjah Mada. And here it is the profile. Professor Kusnanto Josef is a professor and the head of the Primary Service Family Medicine Specialist Study Program at Universitas Gadjah Mada. His area of expertise and research interest is focused on medical and health sciences, epidemiology, public health, and health service. His studies have been undertaken at Universitas Gadjah Mada with both a bachelor's and master's in public health. He obtained his doctoral degree at Yale University with an epidemiology concentration and continued a postdoctoral program at Harvard School of Public Health with an international health concentration. Professor Harry pursued a family medicine specialist at Universitas Pajajaran in 2017. He has written and published numerous journal articles and various publications. Well, ladies and gentlemen, please welcome Professor Kusnanto to lead the session.
Thank you for the introduction. I'm so sorry, right now I'm in the airport of Jakarta, but my flight is about two hours from now. Okay. May first I introduce our distinguished speakers. There are two distinguished speakers who would like to discuss about leprosy as a neglected disease. First is Dr. Anna Schoenmakers. Yeah, she holds medical doctor from graduated from Queen Mary University, London, and primary care postgraduate in University of Amsterdam. She got Masters of Science and Doctor of Medicine from Utrecht University. And right now she is a voluntary as a chairperson for Property Owners Association. Her research is about leprosy, and she will present an update of leprosy as a comprehensive point of view. And this presentation would be followed by a discussion by Dr. Astri Ferdiana. She has medical doctor from Gadjah Mada University, MPH from Royal Tropical Institute, and PhD in Public Health, University of Groningen. Her research interest in TB, spinal TB, and leprosy. And she also now an assistant professor at University of Mataram, and she also member of Research Center Tropical Medicine Gadjah Mada University. She is also now working in NLR Indonesia. Please, first, I would like to invite Dr. Anna Schoenmakers. The time is yours.
Thank you very much for the great introduction. Let me share my presentation. Okay, thank you for the great opportunity to present at this wonderful conference. I would like to present on research priorities in leprosy and experiences from low middle income countries. And I will do so together with my lovely colleague, Dr. Astri Ferdiana from NLR Indonesia. And the outline of this presentation is that I'll first give a short introduction about leprosy and the epidemiology on leprosy, and challenges in leprosy control. And the rest of the presentation will mainly focus on leprosy prevention using post-exposure prophylaxis, linked to research topics and research priorities, and to case studies from Indonesia. So what is leprosy? Just a quick recap for everybody who, because it can be a long time ago for some. Leprosy is a chronic infectious disease caused by Mycobacterium leprae. And it is, I'm sorry, there's a problem with the sound here. One moment. Yeah. And it can affect the skin, mucosa, peripheral nerves, eyes, hands, and feet. The transmission of the Mycobacterium leprae is mainly human to human via a droplet infection, so via the aerogenic route. That's what's been told. And we know that over 95%, and some studies say even 90% of the people who have been in contact with the bacteria do not get the disease because of a well-working immune system. And in addition, prolonged contact is needed with the leprosy patients, usually over 3 months, for example, living together or working together in order to get the disease. The main reservoir of M. leprae are untreated human beings, although in some areas armadillos can also be a reservoir. And early treatments can prevent disabilities. At this moment in time, there are estimations that 2 million people worldwide suffer from leprosy-related disabilities. And leprosy is one of the 20 neglected tropical diseases. So symptoms of leprosy are skin patches or bumps with decreased sensation. You can see it on the upper picture. There is a hypopigmentation lesion. And if you test the sensation in that lesion, you'll notice that the sensation is decreased compared to the skin around it. Nerves can be swollen and painful. Hands and feet can have decreased sensation, and this can result into blisters, but also ulcers and sometimes infections, which can lead to amputations. Problems with muscles and cartilage in hands and feet, which can cause, for example, as you can see on the picture below, which something previously called claw hands, so disfigurements of the hands, and damage to the eyes and face can also happen. And leprosy is a disease which is mainly affecting the ultra poor, and this is because they usually have a poor diet and sanitation, poor access to healthcare, resulting in a lower functional immune system. And the diagnosis of leprosy can also result in stigma, discrimination, social inclusion, decreased mental well-being. And this is a bit of a circle, because if people face discrimination, social exclusion, and disabilities, they will usually get poorer, and then their life is really can be really difficult. What we see is that the number of leprosy patients has been relatively stable over the past 15 years, and you can see that here in the graph. But there has been a decrease of patients over the last years, and this is thought to be caused by COVID-19. And we don't think the patients weren't there, but they just weren't found, because health services were, of course, focusing on COVID. Patients were scared to go to health clinics, and therefore they were not diagnosed. And 80% of the new cases are diagnosed in 3 countries. And this is our number from 2019, so just pre-COVID. And as you can see in Indonesia, 9% of the global patients were diagnosed, so over 17,000 patients. And India is the biggest country with 57% of all cases. But after COVID, those numbers decreased. So in Indonesia, you could see that there were 17,439 patients, and in 2020 there were 11,000 patients. And in India, this difference is even bigger. There, the number of patients was almost cut in half by the pandemic. So these patients are still somewhere, but they're not being detected. And there is an article from Smith and Van Brakel saying the missing millions. We think there are many more patients not being detected who need treatment to prevent disabilities and further transmission of the disease. A challenge in diagnosing leprosy and combating leprosy is that the incubation period of leprosy is very long. On average, it is 4 years, but in some cases it could be 20 years from the moment of infection till the patient recognizes their first signs and symptoms or experiences their first signs and symptoms. And in this incubation period, the disease is already contagious. And this is a real challenge because there are no clear tests to see which persons are in the incubation period and also spreading the disease or will get the disease. Luckily, there is a treatment for leprosy since the 1980s, and this is called multi-drug therapy, MDT, and it's available free of charge via WHO. It's a combination of 3 antibiotics, which a patient should take for 6 to 12 months, depending on the kind of leprosy, the type of leprosy he or she has. And the combination contains the medication Dapsone, rifampicin, and clofasamine. 3 days after starting treatment, the patient is no longer infectious, which is very important information to share with the patient and the family. And if treatment comes too late, disabilities are more likely to occur. So it's vital to early diagnose leprosy and start the treatment. But of course, like in all diseases, prevention is better than a cure. And there is now an innovation in leprosy since a few years, what we call SDR-PEP. And this is 1 dosage of the antibiotic rifampicin, which is also part of the MDT. And this protects for around 57% if you provide it to contacts of leprosy patients who do not have leprosy symptoms themselves yet. So why SDR-PEP? It is important as a control strategy because early case finding and MDT were not sufficient in some areas. There was continued transmission, as you could see the graph about the global number of cases was quite stable prior to COVID, even though MDT was introduced in the 80s. And transmission starts long before the diagnosis, so it would be good to have a medicine which is focusing on that period. And of course, there's also research to vaccines in the world of leprosy. And for example, the BCG vaccine shows some protection, but not very much and not in all cases. Therefore, there's been research going on for a leprosy-specific vaccine called LepVax, but this is still in early stages. And therefore it's expected that it will take years before this is available. And also if it becomes available, this can be given together with PEP. So rifampicin is a well-known antibiotic and it's available since the late 50s. It is also used for leprosy, MDT, like I just said, but also for other diseases like tuberculosis and meningitis. It is cheap, there is no patent on the drug anymore, and the side effects are minor, especially after 1 dose. People usually don't know the side effects. And possible side effects are flu-like symptoms, color change of body fluids, and rash. There was an expert panel discussing the use of rifampicin, single-dose rifampicin in leprosy control, also regarding possible initiation of resistance, especially in tuberculosis. This is very important because resistance there is a problem. And it was told that the risk of resistance when using SDR-PEP for leprosy is negligible. So who are the contacts you would like to treat with SDR-PEP? A contact is someone who has prolonged or regular contact with the leprosy patients, and usually 4 types of contacts are defined. The household contacts, so people living under the same roof as the leprosy patients. The neighbor contacts, those are all people living next door to the patients. Social contacts, people who spend over 20 hours per week with the leprosy patients, for example, schoolmates, colleagues, or people like friends or other people who people met in social gatherings. And community contacts, so people who live in an area where a leprosy patient is also situated. And the SDR-PEP works in this period, so during the incubation period. If a patient or if a contact is already having signs or symptoms of leprosy, SDR-PEP is not working, but MDT, so the full leprosy treatment, should be initiated. So when looking at research about SDR-PEP, what we see is that there were some trials, first focusing on dapsone and later on rifampicin, 2 doses of rifampicin in Indonesia. And there it was found that there was a protective effect of 63%. And this study was followed up by the big CoLab study in Bangladesh. And there a protective effect of 57% was seen when 1 dose of rifampicin was given to patient contacts. And this is really a breakthrough in the world of leprosy, because this meant that we now actually have something to prevent this disease. And this study was followed up by an implementation study called the LPEP program. And this was running in 8 countries to see if SDR-PEP was also feasible when adopted in national programs. And on the right of the slide, you can see the countries listed, which also include Indonesia. And the objective of this study was to generate evidence on the feasibility of integrating contact tracing and SDR-PEP administration into routine activities. And the study contained 3 years of field work, and household contacts, neighbors, and social contacts were included. And the feasibility is important because it's important to demonstrate that it is feasible and safe to use this new innovation. And that the leprosy staff in the leprosy programs is motivated and can be trained to use this innovation as well. And that the access to community is sufficient to hand out SDR-PEP and perform screening. And what was found is that researching social contacts can be challenging, especially in remote settings, or for example, islands far away, which can be the case in some areas in the world. Acceptability was tested as part of this research project, and in 8 countries, more than 150,000 contacts received SDR-PEP, and the overall acceptance rate was over 98%. So the conclusions of the LPEP study were that less than 1% of the contacts refused screening in SDR-PEP, and that it's important to provide clear information. SDR-PEP is unfortunately not 100% effective, but it reduces the risk of getting leprosy by more than 50%. So contacts should still be aware of leprosy signs and symptoms after taking PEP. There were no serious events reported during this study, after including over 150,000 contacts. And it was stated that approaches in which the identity of the index patients can be protected need to be further developed and tested. And this is because of the stigma aspect of leprosy. So in summary, SDR-PEP is cheap, well accepted, severe side effects are rare, antibiotic resistance is not expected, and SDR-PEP is included in the leprosy guidelines since 2018. A colleague of mine, Anneke Taal, performed a modeling study together with Erasmus Medical Center in the Netherlands, and based on this study, including 110 countries, a reduction of 50% of global new cases in 5 years is expected when SDR-PEP is fully rolled out. And the same computer model predicted that 90% decrease of cases is possible in 22 years when widely distributing SDR-PEP. There are some continuous research projects, and I'll present shortly 3 of them. The PEP++ project is a project where Indonesia is also included, and it's organized by NLR, in which rifampicin is combined with clarithromycin, and various doses are given to contacts. And we hope that with this new regimen, the effectiveness of PEP, SDR-PEP, which is now around 57%, will increase to over 19%. But this is early. The research project has just started in several countries, so we hope to get the results in the upcoming period. The PEP for Lab project is a project where I'm working on, and together with an amazing team from various countries, Ethiopia, Tanzania, Mozambique, Germany, and the Netherlands. And here SDR PEP is used, but it's combined with integrated skin screening, also using skin cams. So during the screening process, it's not only focused on leprosy, but also on other skin diseases. And the People project is almost finished. And this is a project running on the Comoros and Madagascar together with university and an NGO in Belgium. And the Royal Tropical Institute in Antwerp is hoping to publish results later or early next year. I expect the results. And they use a double dose of rifampicin. So it would be really interesting to see, what the results are of these research projects. And also, of course, we always hope that more research is being done and initiated. And Dr. Astri will later present on the results or on the research priorities. I'll quickly say something more on PEP for Lab. And this is a cluster randomized implementation trial where integrated skin screening and SDR PEP are combined. And we'll test it in skin camps. And skin camps are community events where around 100 contacts are invited. And those are the neighbors and the close contacts living within the 20 closest houses of a leprosy patient. And what is special about skin camps, that in the skin camps, it's not needed to declare the disease status of the patient. So you could just say, in this area, there is leprosy, and there are also other skin diseases, and therefore we'd like to screen everybody here. And we hope this will decrease stigma and will increase people joining the screening sessions. And the other intervention we're testing is that household contacts of leprosy patients are visiting a health center to receive screening and SDR PEP there. So the skin camps in SDR PEP is what we've seen is that around 100 people usually show up, in some settings even more than that. And the integrated skin screening approach is quite successful. In the skin camp so far, around 50% of the community contacts showing up had skin diseases, and around 1 new leprosy patient is detected per skin camp. In the skin camps, usually a dermatologist or experienced doctor is available. So it's really bringing specialized healthcare to people living in underserved settings. And large skin app, a mobile health application, is being used, which can also support health workers to diagnose and treat skin diseases. In the skin camps, a free medication is offered, topical medication, so creams, for example, and other patients can also receive referrals. And if people are interested to learn more about skin camps, they can always contact me to receive protocols and standard operating procedures. And this is an example of one of the skin camps in Mozambique. And as you can see, it's very well visited. So you can already start now with SDR PEP. You don't need to wait for the extra research, although it's always good to do more research. And there are various contact approaches, for example, the standard approach, where you can include around 20 close contacts of a leprosy patient. And self-screening approach, where people screen themselves and present themselves to health centers if they have signs and symptoms of leprosy, and the rest can receive SDR PEP. A blanket approach, where the whole area is targeted. Skin camp approach, which I just explained, and drives or retroactive case finding, where a small team is going to areas where retrospective patients have been diagnosed to hand out SDR PEP and perform screening. And we've developed a decision support tool where you can decide which method is best to use for a specific context. And this tool consists of a description of implementation approaches and also a flow chart where you can see which method is best for your specific situation. And that really depends on some basic requirements. For example, are there health services available in the area, and is there a surveillance settings for surveillance system for contact screening? Is there trained and motivated health staff? Are Are there sufficient research sources such as the MDT and of course rifampicin, but also community information and education materials are very important. How endemic is the setting? Do you need to do drives or skin camps to cover a whole village or maybe even a blanket campaign? And what is the level of stigma? Because if there is high stigma level, it's preferred not to it's preferred to conceal the disease status of the index patient. And then, for example, blanket approach or skin camps may be more suitable. And at the end, the accessibility. If roads are really difficult to use, it may not be easy to go to settings multiple times, and a blanket approach can be a better solution. So as said before, SDR-PEP is included in WHO guidelines, and also there are some practical guides on the use of SDR-PEP. So I would advise everyone to look into this. And NLR has made a video on SDR-PEP. I'm not sure if the sound of the video will work now, but otherwise you can all go to www.nlrinternational.org/SDR-PEP to watch the video. And there are various country versions available. So if you want more information on leprosy or cost-cutting issues around NTDs, please visit info.ntd.org, infolab.org, or nlrinternational.org. And I would like now to hand over to my colleague, Dr. Astri, to present on the Indonesian pilot studies and, of course, on the research priorities. Thank you very much.
Very much, Anna. And,
thank you very much, Dr. Anne Schoenmakers. It's very important that prophylaxis, chemoprophylaxis with single dose of rifampicin, and probably double dose, and probably with clarithromycin, yeah, and also screening, I think hopefully will end transmission of leprosy. And for the next second speaker, please, Dr. Astri Ferdiana. The time is totally yours. Thank you.
Yeah, thank you, Prof. Hari. I hope my voice is clear enough. Yes, following on Anna's presentation, I will present about research priorities in leprosy and experience from Indonesia. Wait a second. So again, I'm introducing myself. I'm Astri Ferdiana. I'm a technical advisor in leprosy control, research and innovation in NLR Indonesia. And this is a joint presentation with Anna from NLR International and Janet Matani, the Research and Innovation Officer from NLR Indonesia. So Anna has presented how leprosy is still being a global public health problem. And many people don't know that Indonesia still face leprosy as a significant public health problem. So in 2019, we ranked third in the number of leprosy cases, as Anna has also shown to you. And we ranked third after India and Brazil. And we still have the same rank even this year after the COVID-19 pandemic. So although we have achieved the national leprosy elimination in the year of 2000, there are still 6 provinces in Indonesia that have not eliminated leprosy. So the recent data in 2021 showed that we still have around 12,000 cases on treatment, and with around 11,000 new cases. And unfortunately, there are still a significant percentage of cases found with already grade 2 disability, which means a visible deformity of the body parts. And the rest are grade 1 disability, which is non-visible impairment, but still can cause an impairment. And more than 10% of the new cases were detected among children, which shows that there are still transmissions of the bacteria because children normally don't have that much contacts with other people. So they might live in close context of, they are being in the close context of index cases that may not be currently on treatment. And most of the new cases in Indonesia still concentrated in the eastern part, the Sulawesi, Maluku, and also Papua. So in the previous presentation by Anna, it was already mentioned about the vision of zero leprosy in 2030. So in the long term, we wanted to achieve zero leprosy, which means zero infection and disease or zero transmission, zero disability, and zero stigma and discrimination. So the goal is really the elimination of leprosy, which means that we have to achieve interruption of transmission. So in 2030, it is a vision that no more countries report new autochthonous cases, which means that it is a original case from or indigenous case from the country, and 70% reduction in the annual number of new cases. And it is also vision to achieve 90% reduction in the rate of new cases per with grade 2 disability per million population, and reduction in new child cases per million children. And how to achieve this? So they have established 4 strategic pillars. The first one is to implement integrated country-owned zero leprosy roadmaps in all endemic countries. So Indonesia already have leprosy roadmap in 2019, the last one, and we are currently develop a national action plan to towards zero leprosy. And the second pillar is to scale up leprosy prevention alongside integrated active case detection. The third one is to manage leprosy and the complications and prevent new disability. And the last one is to combat stigma. We have discussed about PEP, the post-exposure prophylaxis, in the previous presentation. And this is one of the key intervention for leprosy prevention, because there is no vaccine yet for leprosy. So the key preventive intervention now is really the post-exposure prophylaxis to curb the transmission of the disease to the contacts, especially. So I want to draw your attention on why research is needed in achieving zero leprosy. So in all areas of zero leprosy, we actually still in much necessity of research in order to develop new and better methods and strategies. So when we apply this to zero leprosy, we need to know better about transmission and how to interrupt it. We need to know better about disability because of leprosy and how to prevent it. And we need to know more about stigma and how to eliminate it. And when it comes to transmission and how to interrupt it, again, I would like to emphasize that now we also focus our research on the effectiveness of post-exposure prophylaxis and also how it is better implemented in leprosy endemic countries. So there have been two groups globally that have conducted assessment on research priorities and in leprosy. The first one is the Leprosy Research Initiative, or LRI. This is a global consortium on leprosy which pools all the global research funding for leprosy into one pool and distributed to researchers worldwide to conduct leprosy research and capacity building. So they have identified several key research priorities, and PEP is one of the research priority, especially how to define and implement optimal post-exposure prophylaxis strategies and regimens, either chemoprophylaxis or immunoprophylaxis. And the second group that has produced research priorities on leprosy is the Global Partnership for Zero Leprosy. So this is also a global consortium consisted of international organizations working on leprosy, and NLR is one of the key member in the GBZL. And they also put post-exposure prophylaxis and transmission as one of the key research priority. So the GBZL further, they divide the PEP as a research topic into subtopics. So there are 17 important subtopics within the PEP as a research topic. And if you are interested to know more about this potential research topic, you can go to the website of the GBZL and see that there are still many gaps in the research on PEP. So when it's being explored, there are still some gaps in research on post-exposure prophylaxis. And some of them are very applicable for Indonesian situation. So, for example, number 3 is the test for different PEP interventions should identify optimal protocols, because given the situation of Indonesia, the vast geographical situation, and then also the decentralized health systems, and also the introduction of new programs embedded in the community, it will be very important to test for different implementation of PEP distribution, so we can know which type of PEP intervention fits best with which epidemiological setting. Because also in Indonesia, there are still high endemic areas, but there are also low endemic areas. And also in Indonesia, we know that in many health programs, including leprosy, there is a huge involvement of community health workers and also health cadres or volunteers or kader kesehatan. So it will be very interesting to assess the quality of leprosy screening by these lay health workers, and whether the quality of leprosy screening by these lay health workers are sufficient to justify their involvement in PEP activities, and what kind of condition that works best to involve them. So these are all the gaps in research on PEP that you might be interested to explore more as researchers. And there are still many questions remaining about PEP. So the single dose rifampicin or SDR PEP in Indonesia. So we follow the WHO guideline to use single dose rifampicin as post-exposure prophylaxis, and it has been actually integrated into the national leprosy control strategies in the Permenkes number 11 in 2019. So actually, although the studies on PEP has been was already conducted in 2015, as Anna also mentioned, but the introduction of PEP into the national policy on leprosy was actually done only in 2019, so it's not really that long. And then in 2020 there was a COVID pandemic, so the rollout of the SDR PEP in Indonesia has not been that extensive. But there have been some provinces, as you can see in this map, that have already started to provide PEP, although the scope is also limited to several puskesmas or even several villages. So in the next few years, we hope to see more areas adopting and implementing the SDR PEP distribution. So in Indonesia, we also use the single dose rifampicin of 600 milligram for adults, and we apply different doses for different age groups. So we only administer the SDR PEP to populations above 2 years old, and it is given to close contacts of index case, around 20 to 50 people. It might be different between areas depending on the capacity of the district health office to implement the intervention. And it can only be given after screening of leprosy symptoms. So those with skin patches or suspected cases cannot be given SDR PEP if they're not confirmed as negative for leprosy. And also for people with specific conditions, for example, tuberculosis and liver disease or renal disease cannot be given SDR PEP because their metabolism might already alter. And the drug only produce minimal side effects, maybe only some effect in the urination, so the urine becomes a bit red. But after all, there are no serious side effects. So I want to present 2 case studies. So we have done, or we are currently conducting 2 interventions on PEP in several districts, but I would like to present only 2 case studies in West Java. The first one is in Indramayu. So it is the post-exposure prophylaxis and community, or called as PEPCOM. So it is a 5-year intervention, consists of 3 approaches. The first one is capacity strengthening for health workers, and then provision of SDR PEP to close contacts of new leprosy cases, and supported by intensified case finding, so more new cases could be found. And the last one is community participation. So Indramayu is one of the endemic district in West Java, together with other districts such as Cirebon and also some other districts in the north coast. So the long-term objective of PEPCOM is to reduce the number of new cases of leprosy and achieve leprosy elimination, and to reduce the number of cases of leprosy in children by 50%. And as a short-term objective, we wanted to achieve 90% coverage of leprosy prevention, the SDR-PEP distribution. And we also want to recruit and involve Sahabat Kusta, or what's so-called multiplying agents that expected to participate in disseminating information on leprosy in the community in two sub-districts. And we also do some intervention to involve the community so that they can actively refer people with symptoms of leprosy to the Puskesmas. So, so we use a kind of a modified approach for SDR-PEP distribution. So the first one is contact approach, which Anna has explained. So it's a distribution of the drug, the SDR-PEP, by the health worker with a bit of community involvement, like CADER, but the screening and then the distribution of SDR-PEP are mainly conducted by the health workers. The adapted version, the part, or we call it like we call it as a participatory approach, is also the distribution of the drug, the SDR-PEP, is conducted by the health workers. However, in this approach, the screening of leprosy skin patch is partially done by the community, which is the family members. I will explain it in more detail in the next slide. So in the contact approach, we implement this approach in 46 Puskesmas, and the 3 other Puskesmas use participatory approach. So this is the comparison between the two. So in the contact approach, first we do the listing of new leprosy patients and contact, and then the leprosy health workers will visit the house of the new case and then conduct contact screening to the household contacts and also the social contacts. The maximum number is around 20 contacts to be screened. And those with suspected skin patch will be re-examined by the health workers at the primary, at the Puskesmas. And if they are confirmed positive, then they will not be given the chemoprophylaxis, of course, but they will be enrolled into the multi-drug therapy for treatment. And those with no patch, so they are those who are confirmed negative, will be given SDR-PEP and they have to take it in front of the health workers. So because of the limited resource in the Puskesmas, because they are also it will be quite a very labor intensive for them to conduct contact screening to 20 contacts per new case. So if you have kind of you have like a 100 new case, then you have to screen around 2,000 contacts. So that's why we kind of modify this approach into participatory approach, in which we involve the family and community in the screening. So the first thing to do is to list the new leprosy patients and contacts, and then health cadres will distribute self-screening forms to households of contacts, and the family members will check themselves or check their other family members for skin patch. So we call it periksa bercak. So all the red or white skin patch should be suspected as leprosy symptoms. And then within 1 week or maybe later or in other agreed time, the leprosy health workers and the health cadre will visit the location, and those with suspected skin patches will be examined by the health workers at the Puskesmas. And then again, those who already confirmed negative for leprosy will be given SDR-PEP. So it's a bit different in terms of who conduct the first screening. And these figures show the difference in the coverage of SDR-PEP between the contact approach and the participatory approach. And it shows that in 2021, for example, the PEP participatory approach yielded higher coverage in the PEP distribution. And in 2022, it was a bit lower, but it was because we haven't finished all the entry for the contacts and the SDR PEP distribution. But the previous the other graph show that PEP participatory can produce a higher coverage of SDR PEP rather than the pure contact approach, which is done by only the health workers. So I would like to bring you the other case study in Subang, the neighboring district of Indramayu. And the project is called PEP BCC, and it is a 3-year project, consists of advocacy, capacity building, and health promotion approaches. And it is a bit different approach from PEPCOM because in this project, we emphasize more on behavior change strategy. So yeah, Subang district is also still endemic for leprosy in West Java, with a prevalence rate of more than 1 case per 1,000 population. And in 2019, we still found more than 100 new cases. And the objective of this project was to increase the participation of health center staff and the community in the case detection and SDR PEP administration using a BCC approach. So BCC is a communication strategy that encourages community to adopt positive health behavior practice towards leprosy. So the steps in BCC implementation is first we select the intervention area, and then we conducted advocacy to the health authority, and then we conducted BCC training to the health workers. So because currently it's kind of a tradition in the Puskesmas that leprosy is the work of is exclusively done by leprosy health workers without or minimal involvement of other health workers. So that's why in the BCC training we involve as much as possible health workers other than the leprosy health workers, including the head of the health center and also the health promotion staff or the health promoters. And then we conducted workshops at health centers for all health center staff, so they would be sensitized better about leprosy. And then we also involve influential community members. So for example, the tokoh masyarakat, tokoh agama, and also teachers, all the important village figures in the target areas. So we conducted workshop to involve them in the leprosy promotion. And then we also encourage them to be more aware of leprosy symptoms and refer any person with skin patch or the suspects to the leprosy health workers. So anyone with a skin patch with bercak should be identified and sent to the Puskesmas for further screening. So in 2021, there were 177 suspects referred by the community, influential community members. And out of this number, about 14 or maybe less than 10% was confirmed as a new case by the leprosy health workers. And we also compare the SDR PEP distribution between the two intervention areas and compared to the coverage of the overall district. And we found that in the Puskesmas that implement the PEP PCC, the coverage of the SDR PEP was higher than the district coverage. So it shows that the involvement of the community in the case finding and also in the SDR PEP show increased coverage compared to those conducted by only the health workers. However, of course there are still remaining questions. So because we conducted these projects not as research but as projects, so we still need to examine further the effectiveness and also what type of intervention works best in different settings, and how cost effective this two intervention, for example, between contact and also between the community participation, which one is more low cost, and what is the quality of the screening performed by these non-health workers like cadres, and also whether the SDR PEP are still effective after more than 2 years. So as a take-home message, and also to end this joint presentation, so more research are still needed in the field of leprosy, especially those encompassing topics related to the 3 zeros, transmissions, disability, and discrimination. And in zero transmission, the key strategy is not only early diagnosis and treatment, but also prevention using post-exposure prophylaxis. However, the coverage of PEP is still low, and that's why we encourage you to do more research to explore this issue. And PEP has been established as one of the effective intervention for cutting off the transmission. However, future research is needed to identify the effectiveness in real-world settings. So if you need more information on research topics and funding on leprosy, you can drop me a message on my email, astri@nlrindonesia.org.id. And of course, if you need, I can also transfer you to Anna if you have more questions. Thank you very much, and we hope that finally Indonesia bebas dari kusta. Terima kasih, and thank you very much.
Thank you very much, Dr. Astri. We still have one presentation by Mr. Achmad Naufal Azhari. He got a bachelor and master public health from University of Indonesia, and now I think he worked at WHO, NTD. He participated in national seroepidemiological of COVID-19, I think with Dr. Iwan Aryawan, Dr. Pandu Riono, and the team from Universitas Indonesia. Please, Mr. Achmad Naufal Azhari, discuss your topic about the gaps in research for neglected tropical disease. The time is yours. Thank you.
Thank you very much, Chair. I hope I'm audible for all of you. I would like to request the organizer to help me to share my presentation, please. Okay. Once again, thank you for the opportunity. Good morning, good afternoon, and good evening, everyone. My name is Naufal. I have been working with WHO Country Office Indonesia as NTDs focal person since 2015. In this occasion, I will share an interesting topic regarding the current gaps and research opportunities in NTDs area of work. Why is it interesting? Because by definition, limited resources for research and innovation has been identified as one of reasons why we obtained this unfavored name, the neglected. So in the next 20 minutes, I'm going to share some operational research topics, idea, and opportunity with all of you to contribute more in NTDs elimination and eradication program. Next slide, please. Let's start with the definition of NTDs. Next. So I would like to use this picture to illustrate NTDs. This is the global burden of disease in 2019. You may see there are 3 different colors. Red is for communicable disease, blue is for non-communicable disease, and green is for diseases that are related with accident. Most of NTDs are considered as communicable disease, but the question is, can you find them in this diagram? No. The answer is no. In my screen, the most readable communicable disease are only HIV, TB, malaria, diarrhea, STI, and other communicable disease. And does it mean we are free from NTDs? The answer is also no, because we still have these small boxes. Next, please. And yes, they are NTDs in the small boxes. Next slide. This is the list of NTDs. Just next. So based on recommendation of WHO advisory group, we still have 20 diseases that are globally considered as NTDs. They can be caused by bacteria such as leprosy and yaws. It can be caused by virus like dengue and chikungunya, and I believe you will hear more about dengue and chikungunya tomorrow. Or it can also be caused by parasite, for example, in particulariasis, schistosomiasis, STH, and rhiniasis, diffusor COVID. Referring to the name, majority of the NTDs can be found in tropical countries like Indonesia and affect people who live in remote, isolated area and in the poorest setting. Most of NTDs are vector-borne disease or have animal reservoir. In 2019, it was estimated that around 1.5 billion people around the world requiring the treatment for NTDs. Next slide. So in January 2021, just last year, WHO published a new roadmap for NTDs program to cover 2021 to 2030 period of time. There are 4 targets that must be achieved by 2030, starting from disease control to eradication. There are 2 diseases targeted for eradication, yaws and dracunculiasis. This is the most ambitious target in NTDs program. And similar with other diseases like polio, the eradication certificate will be released once all countries declare free of these diseases. The second target is elimination, which means the interruption of disease transmission in a specific area. It can be at regional or national level, country level. The third one is elimination as a public health problem. That is targeting the elimination of morbidity or reduction of disease transmission. And the last but not the least is the disease control. Next. This slide shows the heat map that illustrates gaps or issues in NTDs area of work. So actually, behind the ambitious target, we are still struggling with a lot of issues that are indicated with the red boxes in this slide. Majority of the issues can be grouped into 4 areas. The first one is diagnostic. For example, in leprosy, we just heard from 2 experts. We still depend on clinical presentation to diagnose leprosy, and more sensitive diagnostic kit, which is essential in pre-elimination setting, is still being developed by our experts. The second area is in monitoring and evaluation, where post-validation approach or strategies are still being developed for some diseases like LF. The third and fourth, the most challenging areas, at least from my perspective, is how to ensure a sustainable access to NTD communities and funding. Because many people think that the elimination of NTD is the finish line, which is incorrect actually. We have to make sure all resources like drugs, diagnostic kit for NTDs after we reach the elimination or eradication target is available for everyone. Next. So considering the urgency of operational research to address all issues in the previous slide, our colleagues in WHO CRO organized series of activities last year to prioritize operational research area for accelerating NTDs elimination and eradication in Southeast Asia region. 5 main approaches have been done, starting from initial identification, reviewing relevant documents, interviewing experts, collecting inputs from relevant stakeholders in NTDs ecosystem during a virtual workshop, and finally a virtual survey to quantify the prioritization of each operational research area. Next slide. This is the illustration on how we finalize the prioritization of operational research topic, and the result can be seen in the next slide, please. Okay. Based on the output of the activity, we have identified top 5 operational research topics for each disease. I will start with dengue. As you can see in this slide, experts suggested to focus on how to ensure the availability of effective referral system to improve the case management, improvement of diagnostic kits, evaluate the acceptability of Wolbachia rollout. We will hear more about the Wolbachia tomorrow. Evaluate the use of current biomarkers in dengue infection, and explore the effectiveness and acceptability of targeted IRS for dengue control. In leprosy, the main concern is in the development of more effective drug or drug combination to combat leprosy, especially with the threat from antimicrobial resistant tissue. For leprosy, there are 2 areas related with diagnostic. The first one is for diagnosis purpose, how to obtain or develop a more sensitive point of care diagnostic kit. And the second one for detecting or monitoring the nerve impairments among leprosy patients. Next slide, please. In lymphatic filariasis (LF) area, experts raised the issue on how to identify persistent hotspot areas, because many countries, including Indonesia, have reported this issue and how to mitigate this problem. There are 2 issues that are related with mass drug administration in LF area. The first one is to explore the impact of never treated population. Never treated population means a group of people who never received preventive chemotherapy for LF. The second one is how to develop more effective MDA strategy in urban settings. 2 remaining areas focus on MMDP, morbidity management and disability prevention, how to better estimate the burden of chronic disease, and how to ensure health system can accommodate the essential package of care for people affected by filariasis. For schistosomiasis, some of you may aware that Indonesia is the only one schisto-endemic country in the region. As the role of snail, the vector, is very much significant in schisto transmission, experts suggested to focus on how to develop better snail control technology. 2 other operational research topics are related with better intersectoral collaboration and health system, because schisto cannot be managed only by health sector. We need collaboration with other sectors, especially with the animal health sector in Indonesia. We also need more input on the list of criteria for stopping the MDA for schisto. And the last one is to develop more sensitive diagnostic tools, especially for Schistosoma japonicum that is endemic in Indonesia. Next slide. And then the last one is for visceral leishmaniasis or PL. Indonesia is not endemic for this disease, but some of you might be interested with this disease. So you can see the top 5 OR topics for this disease. Next slide. Okay, this is my last slide. The full report of our operational research workshop was just published on 2 November in our website. If you are interested, you may download the report in link in your screen. Thank you very much for your attention, and over back to Chair. Thank you.
Thank you very much, Dr. Naufal. I think this is a very a good summary of what have to be done in the research to control, to eliminate neglected tropical diseases. And now I think we would open for question and answers. So first, we have a presentation by Dr. Schoenmakers about leprosy, general overview of leprosy, and Dr. Astri presented the results of her research in Indramayu, including social and behavioral perspectives. And at last but not least, Mr. Naufal described the overall gaps in research of neglected tropical diseases. Yeah. Please, if there are any question, comment, clarification. Yeah. Probably we can look at the chats. There are questions from the chats, yeah. Okay. The decrease in the number of new cases is largely due to less intensive case finding because of the, yeah. So I think this is related to why there were less intensive case findings recently, during the COVID-19 pandemic. Is that true? And also the screen for comorbidities and asking the contact for history of this condition prior to single dose of rifampicin chemoprophylaxis administration. Okay, so please, Dr. Schoenmakers, if you have response to the question about the impact of COVID-19 pandemics to leprosy.
Yeah, thank you very much for the great question. What I think my colleague Dr. Astri already also replied in the chat about the situation in Indonesia. What we see on a global level is that there was a massive decrease of new cases of leprosy after the COVID pandemic started. And in this case, a decrease of patients is not a good sign because we think it's caused by lacking healthcare access. And of course, the healthcare programs needed to focus on the acute situation of COVID-19. Therefore, there was there were less resources available to focus on leprosy. And leprosy has a very long incubation period, as I explained, on average 4 to 5 years. So it's unlikely that within 1 year there were less patients. For example, that patients were almost cut in half in India. So we really think this is caused by COVID. And we already see that the patient numbers are increasing again since COVID has been a little less acute in the recent year.
Thank you very much, Dr. Schoenmakers. Dr. Asti, would you add some perspectives on the question?
Yeah, thank you, Prof. Hari. I think we also face a similar challenge in Indonesia, especially during the peak of the pandemic in, I think it was in the end of 2020 and in the middle of 2021. And the challenge in leprosy control was not only because of the restriction of mobility, but also because of many health workers were being affected by the disease, and as a result, fewer health workers can be involved in leprosy control strategies. So all the case finding activities were kind of significantly affected, and it was improved a bit in the end of 2021, when the vaccination started, but also because of the vaccination campaign, which was very intensive, many leprosy health workers were being averted to help with the vaccination. So they have kind of a double burden in COVID-19 response and also still doing the leprosy control activities. So that's why all of these events finally resulted in very significant decrease of number of new cases. But we hope that this situation will improve in the next few years.
Thank you so much. If I'm not mistaken, I saw the decline of leprosy notification was even before the pandemics. And in 2020, you showed an increase even of notification. So do you have explanation for this phenomenon?
Yeah, the process in reporting leprosy new cases is actually so the new cases reported in 2020 is actually the total number of cases detected in 2019. So if we present a figure in 2021, it means that it is figures of 2000 the year before. But maybe Mas Naufal later can also explain about this reporting mechanism in leprosy. But the trend of the decreasing trend was already observed in 2020 because it was really severely affected the health sector.
Please, Mas Naufal, do you have observations on the similar observations on other neglected diseases? I mean, the notification affected by COVID-19 pandemics, because the focus is on how to control the pandemics.
Yes, I think it's not only observed in NTDs area of work. I think in all communicable disease, we can observe that the trend is slightly or maybe dramatically decreased during the pandemic in 2019, 2020, and early 2021. For leprosy, specifically for leprosy and NTDs, people think that it might be because of the pandemic, but honestly, I think it is not a confirmed answer. We just expect. And for Indonesia, we will try to explore about this in early 2023. WHO, in collaboration with the Ministry of Health, will try to perform a joint program review and see how much the impact of pandemic into the national program of leprosy. So we will see later in early 2023.
Thank you, Mas Naufal. Is there any other questions? Please.
I think in the question and answer box, Prof, there are some questions next to the chat box.
Oh yeah, the chat box.
Yeah, a chat box, and next to it is the Q&A box.
Yeah, I'm sorry, I'm using phone now, but I could not find.
All right. Shall I read the question?
Yeah, please. And
okay.
Who is the to whom the question is directed?
This is from Nadila Beladina. Question for me.
Yeah.
Based on the research that you and your team conducted, do you find challenges that the health workers might face in implementing the SDR PEP program? Sorry, and how to tackle those challenges? Shall I answer directly? Okay.
Yeah, you just respond to the question.
Okay. Yes. Thank you for the question. And Yes, indeed. The SDR PEP program is not without challenge, although I think we got the impression that giving drug SDR PEP as a pill is much easier than giving vaccination. So during the last few years, you know that there has been some resistance to COVID-19 vaccination, but in the SDR PEP, it's much lower resistance from the community. And we also, in one of our baseline survey, we asked the community whether or not they will be willing to take leprosy prevention drug, and around 98% say that they will be willing to take those drugs. And other challenge is, of course, the limited resource of the health workers, not only because of the COVID-19 pandemic, but also because usually the leprosy health workers have other responsibility in other programs. So in some puskesmas, for example, they have to be responsible for TB and leprosy, and you know that TB is very much intensive program. Or in other puskesmas, they have to also be responsible for health promotion or other big program. So this is a challenge in conducting the SDR PEP. So that's why we one of our projects is really to encourage community participation in not only the case finding, but also to conduct self-screening, so it will reduce the burden to the health workers and the health system in general. And the other challenge is the logistics. So the single-dose rifampicin in Indonesia is not really freely available. It's very cheap, but it has to be procured through the National Leprosy Program and through the what do you call it, the Dirjen Pharmacy. And then so there is sometimes there is a problem in the supply chain of the SDR PEP and also the leprosy drug, the multi-drug therapy. So sometimes when the health workers are ready to implement the SDR PEP distribution, but the drugs are not there. So that's one of the challenge to really scale up the PEP coverage. That's
thank you very much.
For me.
Yeah. You still have more comments, Dr. Astri? Dr. Astri?
Yes.
You still have more comments?
No. Thank you. Thank you, Prof.
Is there any other question?
Maybe Anna, there is another question on the resistance.
Resistance
AMR.
to rifampicin?
Yes, I think so, Prof.
Okay. Do you have any answer for that question?
Yes. Let me see. The question is if it was mentioned that the risk of microbiological resistance of leprosy PEP is negligible, even though PEP is a single dose administration of the antibiotic. So there has been an expert meeting on this together with also TB experts and leprosy experts and microbiologists, and they discussed this, and they think one dosage is not enough to start resistance. What they stated was that it's still very important to focus on resistance surveillance, especially when introducing SDR PEP. So this is also something which we really advocate for. I know, for example, in Tanzania, they are now setting up a laboratory for this, and they hope to do more research on this, which is, of course, very important to do. And the WHO has clear guidelines also on antibiotic resistance surveillance. And this should not only be done in leprosy, but also in TB, because rifampicin is an important agent in the combat to stop TB. But at the moment, we think because it's just a short dosage, it won't be a problem, but continuous research is being done and needed for this. Thank you very much.
Thank you, Dr. Schoenmakers. So stop TB and eliminate leprosy. and related
That
to
would be
rifampicin
wonderful.
resistance. Yeah. Jeff, please, final comment, Dr. Schoenmakers. Final comment about leprosy control or elimination or prophylaxis?
No, I just hope that yeah, we can all work together as a global community on the fight against NTDs and also leprosy. That innovations like SDRPEP, but hopefully also newer innovations will come up. And I think it's important to also stimulate junior researchers to work together and health workers and persons affected to really work together on this. And again, I'd like to thank you for inviting me to present on this important topic. Terima kasih.
Thank you very much. Dr. Astri, do you have any final comment related to your research? Yeah.
Yeah, thank you, Prof. Harry. Yeah, I think yeah, many still research potentials to do in Indonesia. So we really encourage junior researchers to. We hope that with this presentation we'll draw more attention to leprosy research, and we are also open to for a discussion if you are interested in doing more research on leprosy, either as a master thesis or a doctoral thesis. The opportunity is very much ample. It's we don't want to be alone in this journey, so hopefully there are more researchers join us in the global efforts combating leprosy. Thank you.
Thank you so much. Dr. Naufal, please, if you have any final comment on your presentation, the gaps in research for NTDs.
Yeah, thank you. So from my side, achieving the target of elimination and eradication of NTDs will be impossible if only WHO or the Ministry of Health who work in the country level. So I encourage all of you, the academic, from academic institution, even community member have a specific role in this elimination and eradication of NTDs. I think together we can achieve this ambitious target by 2030. Thank you.
Thank you very much for all the speakers. I think a big applause to three of you. And thank you also for the attention for the participants of the Zoom. I'm so sorry because as a moderator, I'm now ready to boarding. Thank you so much.
Thank you, Prof.
And see
Safe
you.
flight.
Yeah, thank you so much. See you in the next opportunity seminars.
Yeah, thank you.
Thank you so much.
Excellent. Thank
yeah.
you.
Thank you. May I leave